we could be much better prepared for the future. As I keep telling people, the pandemic clock is ticking. We just don't know what time it is.
Dr. Michael Osterholm is an epidemiologist and the director of the Center for Infectious Disease Research and Policy at the University of Minnesota.
Science is not truth. Science is the pursuit of truth.
He has served in a formal role for every presidential administration since Ronald Reagan, advising on topics related to public health, pandemics, and biosecurity.
Living during SARS-CoV-2, where 1.5% of the people died. Now imagine if you put a 15 or 20% case fatality rate on that, what would this world be like?
We talk about lessons learned from the COVID-19 pandemic, including how to communicate evolving science to the public, the value of conducting a formal review of the governmental response, and the risks of defunding pandemic preparedness. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Michael, welcome to Stanford.
Well, thank you. It's a real honor to be here.
We're so happy to have you, and you just played our medicine grand rounds to a packed audience, standing room only. I'm excited to talk to you today for so many reasons, and for the important voice you've had for the US and for the world in relation to many threats, but of course particularly pandemics. Before we get to that though, I'm always fascinated by people's stories. Like, how did you get to be one of the world's leading voices on pandemics? And as we'll get to, somebody who really saw it all coming. But take me back much further. Take me back to your childhood. Where did all this start? Where did you first get an interest? Tell me where it all began.
Well, thank you. Actually, I do know, to the moment almost, how it all began. My father worked in a small Iowa farm town newspaper, and the owners, a husband and wife team, were really what I would call Renaissance individuals in this town. And the woman subscribed to the New Yorker.
Okay.
I think probably the only person back in the 60s, and early 70s in Iowa that somebody subscribed to the New Yorker. And one day I was at their home and I saw the magazine, and there was a story in it by Bertrand Roget, Annals of Medicine story. And I looked at it and I thought, this is interesting. I started reading it. I couldn't put it down. Well, it turned out
How old were you?
I would have been in 8th grade.
And pretty young for the New Yorker. But
well, this story though just absolutely captured me. And so every time that there would be a new New Yorker article with including Bertrand Roget in it, I would quick run up to their house and get it and read it. And I knew I wanted to be a medical detective. And people thought I was, a little whatever.
That's quite specific.
So I never lost that love. And in fact, even during the times of college where people said, well, infectious diseases are dead and gone, they're horse and buggy, I only found myself more interested. And I had the most amazing experience to bring full circle this early childhood interest. When I was a state epidemiologist at the Minnesota Department of Health, we had a very large outbreak of a thing called thyrotoxicosis. This is where there's too much thyroxine in the blood, and thyroxine is the metabolism-related agent. And we couldn't figure out why, because their thyroids were actually shrunken and small, these people. And they were really in very serious condition. Well, it turned out that we figured it out. And it was because the government had just started allowing a thing called neck trimming in their meat processing, where they would trim 2 or 3 more pounds off the neck. But what had happened was the companies that used human bovine thyroid thyroxine no longer needed it because they now had it genetically modified, and so they didn't sacrifice that and get it. And as a result, this was being dumped into the meat that went into hamburger. And so people were eating thyro burgers. Well, the reason I tell you the story is because Bertrand Roget wrote this up as one of his stories, and I had an opportunity to tell him just how important he was to me in my career and my life. And unfortunately, he died shortly thereafter. So I had that opportunity to go full circle with Bertrand Roget.
Well, that's just a remarkable. So I'll have to dig that article out and read it.
Please do.
Thyroid burgers, that's incredible. But also what
it was in the New England Journal of Medicine, and actually we ended up doing. Sid Ingbar, who is an endocrinologist and a senior editor at the New England Journal, actually got so into this with us that he flew out to Minnesota and actually went to the plant with us where this was happening. And needless to say, the article got published in the New England Journal of Medicine. But more specifically, what had happened was the fact that we needed to get some kind of estimate of how much impact this meat would have. So we brought in, through human subject approval, a number of Harvard medical students who got paid to eat this hamburger. And then we measured their thyroxine levels, and actually they were getting about the equivalent of 3 to 4 replacement doses a week extra by eating one hamburger. And so it was clear and compelling. And so thank you to the Harvard medical students who participated in our work.
For making themselves voluntarily thyrotoxic for you.
Yeah.
That is, I mean, that's layers of, I mean, that's what I love, of course, about the log form, the New Yorker writing, is that there are just layers of elements to this that they can get peeled back. What stage were you at when you were doing that work?
Well, it was in 1984. I was, at that time, state epidemiologist in the state of Minnesota. I had been in Minnesota now for 9 years. And, you know, I was very fortunate to enjoy a wonderful experience as a state epidemiologist at Minnesota. And at the same time, being affiliated with the University of Minnesota. So I kind of always had two jobs. I guess, you know, I've not necessarily been fired from any, but I always had two new ones. I also, for example, right after 9/11, because I had written a book that was published in 2020. Let's see, it was published in 2000, and it was one on living terrors, what American needs to survive the coming bioterrorist catastrophe, and it was all about bioterrorism. And so when 9/11 happened, Secretary Tommy Thompson, who was at that time the Secretary of Health and Human Services, asked me to come to Washington. So I split my time 50-50 with him and back in Minnesota, and did a lot of work on bioterrorism related to that.
Yeah, amazing. You really have spent many years thinking about things that can kill us, and that's going to be the theme here. But also as somewhat of a soothsayer, I think. One of the really striking elements of the talk that you just gave, you showed us some emails and some of the early warnings you had served. Not least with a whole book. First of all, you talked about one of your books, but you have another one called Deadliest Enemy, which was published 2017.
2017, yeah.
Well, tell us about that.
Well, that one was kind of a landscape review of infectious disease issues. As you misnoted earlier, some people want to know why we went into infectious diseases. This book was really a way to update, to say this is why, because there's a lot of significant issues ahead. And 3 chapters were devoted actually to a future pandemic, which we rolled it out almost as it actually happened. However, we ascribed it to an influenza virus, not a coronavirus. And that was important. And one of the chapters actually was titled SARS-MERS, a harbinger of things to come.
And wasn't it ever? Many of us, when we think back, and this is, I think, one of the points you made early on in your talk today, is that all we do is think back. There hasn't really been a formal investigation and a formal kind of post-mortem. You know, in a way, we're familiar with that in medicine. You know, if a patient dies unexpectedly, we do a very careful post-mortem. Despite the global pandemic and certainly everything we lived through there has never really been a formal review at the government level in the U.S.
You know, and I had an opportunity to really understand how important that formal review can be, because part of the time that I spent after 9/11 as an advisor to the Department of Health and Human Services was also when the 9/11 Commission came together. It was led by a Republican and a Democrat. It was very comprehensive. It did not spare anyone anything. It turned over every rock it could, but it was never partisan, never. It was always about what are the things we could have and should have learned. That document served a very important purpose in helping us plan over the years after that as to what can we and should we do to be prepared for another event like that. And so I think that if we had the same kind of review, nonpartisan but comprehensive, we could be much better prepared for the future and another pandemic, because we are going to have another pandemic. As I keep telling people, the pandemic clock is ticking. We just don't know what time it is.
Yeah, and we're definitely coming to that. Because you've been saying this for years. I mean, I think also important to note, you've worked across the aisles, you've worked with multiple administrations. You know, pandemics are not a partisan issue. Like, the viruses don't care.
Yeah, and I think this is where public health is an important entity. You know, I've served a formal role in every national presidential administration since Ronald Reagan, when I worked with HIV/AIDS and the AIDS Commission. And even during the first Trump term, I served as a science advisor to the State Department, a science envoy, working on trying to get the world better prepared for a pandemic. So much for the success of that one. The bottom line is that this is what in public health we need to do is, it's never about partisanship. It's about calling balls and strikes. And I think that's right now, one of the things we're missing with the review of of what happened with COVID is a review of the balls and strikes.
It's not there. It's not there.
It's not there, yeah.
So talking about your ability to predict, you also showed a couple of slides which were just more remarkable to me, not because I think there were some, you were among the more prominent voices, making us beware and think about the possibility of a pandemic. But as it was evolving, so in the December and January of that year, 2020, when things were so new and we were literally just getting the first news reports out of China, and Wuhan specifically, you showed us some of the work from your center and also some personal emails. So you're not rewriting history here. These were written by you in the moment. Just tell us about those.
Well, I think one of the challenges that I've had with any discussion about the pandemic is that it seems to keep changing in people's minds what happened.
Yeah.
And there's a lot of rewriting of history.
Yeah.
And that's one of the things that I think is a real challenge, because that doesn't help us. No. Today I talked about, for example, lockdowns. And what is really a lockdown, and how long do they last, and what could they do or not do? Yeah. And I think the challenge we have is that if you just go back objectively, again, not on a partisan basis, and say, okay, what could we have learned from this? Yeah. Well, in a pandemic that's going to last 3 or 4 years, a lockdown will never work. Yeah. It's temporary. It's isolated. It's like a hurricane. Yeah. It's really bad for 12 hours, but then we go into recovery. Yeah. And so what we needed to do is figure out how can we sustain protecting as many people as possible. And back then, the one thing we had to offer, and the only thing we had to offer, was good medical care. Yeah. We didn't have a drug, we didn't have a vaccine, we didn't know what to do. But if your hospital is running at 140% capacity, and people are in the hallways, people are in the parking garage stalls, in beds, that's not good medical care. Yeah. And so one of the things we talked about is, instead of having lockdowns, have snow days. Yeah. What if every hospital in this country every morning had to publish their bed census? Yeah. And if we were suddenly at 120% in terms of census, let the public know, please, now's the time to back off, if you can avoid group kinds of activities, et cetera, this would be the time. And tell them when the numbers get back down, we'll say, okay, you can go do more things. So it's just practical things like that.
It's kind of both an early warning system, but also there isn't a bed available were you to get ill. Yeah. And then some form of, so it sounds like you weren't supportive of like full lockdowns, like you said, but some degree of distancing would be
absolutely.
Something that people could do.
But it could be tied to that time when people felt like, why am I doing this? Well, because I know why I'm doing it, because my hospital right now is at 140% capacity. If I get sick with COVID in the next couple of days, what am I walking into, or if I can't even walk to get into the institution? And I think if we had communicated to the public more on events like that and explained our logic. What I just shared on snow days is pretty simplistic. Right. But it's also powerful in the sense that we then could hopefully deliver the best medical care we could. Yeah. And that was all we had. Once we had vaccines, we had drugs, et cetera, that started to change things. Yeah. But in those early days, it didn't. Yeah.
I wanted to, something that really struck me, and I wanted just to make sure we don't miss it as we're moving through the sort of pandemic timeline, was that you'd sent an email suggesting that we need to wake up and take this seriously, and at the time people were not. Yeah. And you'd said you were worried that we might lose 800,000 citizens, and it turned out a few months later that was pretty much on the money.
Yeah, I made the statement in late March, early April that I thought that this was going to last for some time, but more specifically, over the next 18 months, we could lose up to 800,000 people. Right. And in an interview I did in a publication, actually went back 18 months after my statement and found that there was 790,000 deaths as opposed to 800,000.
That's a pretty impressive
statistic. Well, I think the other part about that was important is none of it was black box magic. It wasn't a computer program that nobody could understand how the hell you did what you did. Yeah. Mine was on the back of the envelope, just straight math of looking at what percent might get infected. And I think that was another lesson is we promised the information we could provide in these models. Right. And people then wondered, wait a minute, that's not what you told me 4 months ago or 3 months ago.
And I think this is a recurrent theme, not just in COVID, but in other places too, where the complexity of modeling can kind of belie the fragility of the assumptions.
Yeah, exactly. I couldn't agree with you more. I think you're right on the mark,
because you're right. At the time, it seemed like everyone capable of quantitative science was doing some kind of modeling, but the reality was there's a few straight variables that change the entire outcome, and
Well,
those are the ones you need to know.
And the other thing I think that was important is because I had an opportunity to work on SARS and MERS earlier, I had some familiarity with coronaviruses. And one of the challenges that we never really understood is what would happen with different variants. Meaning that, in fact, from the actually ancestral strain to alpha, beta, delta, gamma, Omicron. And as those changed, that changed a lot of what happened. And I provided some data today on children. And the fact, if you look at deaths in children for the first year versus the next 2 years, it was incredibly different. Well, a lot of the data that we used to describe the risk of COVID and how serious it would be to children was from data from that first year. Not realizing that once Delta and Omicron showed up, it was a very different picture.
Yeah, that is not, I think, particularly widely known. I mean, I think we were all following, at the time, the elements of this literature, and that I hadn't particularly remembered that.
Yeah, so and that's the kind of thing, I think, again, where we then tried to legitimize why. In the first year, you probably could have kept schools open more, but in the second and third year, you really were, particularly with Omicron, in big trouble. And had the public better understood that this is why we're changing. We're not changing our mind. We have new data. The point I try so often to emphasize with my students is, science is not truth. Science is the pursuit of truth. And that is so important to understand that's what we're doing. And the public then, if they're given that explanation and said, this is what we're doing to learn more, this is what we're going to hopefully know in a couple more months.
It's a system of rules and rigor to pursue truth. And I think, and importantly, I mean, the way I usually find myself saying that is, it isn't a belief system, other than a belief that using certain rules and rigor, you can pursue truth. And it's our best attempt at that as a human species. It's not a belief system.
There's a lot of mornings I wake up and sit on the edge of my bed before I get up, and I say to myself, man, I wish I could know today what I'm going to know 6 months from now. And how to convey that as a message to the public so it says, it's like the weatherman, okay? I'm not going to give you the same weather forecast 27 days in a row. It's going to change. And that doesn't mean that the last one was wrong. But why does it change? And this is what I need to report to you. When we see changes,
the estimates change.
The estimate changes,
The current narrative on the lockdown question is that we lost a lot, of education of children, and when we were at least the school closure part. And that if we'd known now how much we lost, and certainly there's a generation of people, including my daughter who was in high school at the time, we can all think of examples, who lost a great deal. Of course, there's no right answer to this, but knowing what we know now about the downside of school closure, maybe which we didn't know as well before, and having a clear view in the rear view mirror, at least, of each of these variants and their impact, do you think that in retrospect, we all, looking at the data, would have made the same decisions? Or, because there was we talked about the Barrington Declaration and the whole approach to that, which was, a challenge.
Well, again, I don't really think that we would have changed much, in the sense that in the early days of the pandemic, we were obviously sensitive to children dying. That is very different than somebody my age dying, and how people perceive that. But we never really did put that, I think, into the perspective of, so what would happen if we didn't shut down schools or close schools? And I'm not always a proponent of saying shutting down a school means you reduce the risk, because if in fact you have your kids all getting together at somebody's house the day that they're not at school.
Maybe with an elderly relative.
Exactly. And so I think the other part of it, though, is that latter part where when the years 2 and 3, 2021, 22, 23, we actually at that time had this big increase. 87% of the deaths that occurred in kids in this country occurred in the second and third year of the pandemic. Would we have thought about, well, maybe we need to think now is the time that we would shut down our schools, with the also recommendation that not then just become a community event where you then socialize and so forth together. I think the other part of that, though, also is the fact that in terms of what we think of with children, we've never really understood the fact that if you don't have teachers, if you don't have janitors, if you don't have administrators, can you have a school open? And what we forget is that many of the schools that closed down, one of the primary reasons, they had nobody to teach. And so, I mean, do you want to send your kids to place where there's one janitor serving as the monitor in a huge study hall.
Yeah.
That was what we saw. So it, again, it's not a right and wrong answer.
No.
It's about how do we have these discussions? How should we think about this?
Yeah.
You know, what is the path of least impact in a negative way versus the benefits of a positive outcome?
One of the things that I always was fascinated by, having learned as a medical student about aerosolized viruses, was the extent to which we were still stuck in a kind of hand-washing touch mode of transmission, despite the fact we knew this was a respiratory virus.
Yeah.
And one of the interesting things was just how all of a sudden, of course, everybody who had expertise that might be relevant, really flooded into that zone. And so we had a lot of physicists and aerosol scientists suddenly in the zone. But what you were saying today was that you already knew this, and that we'd already learned this from the earlier SARS.
One of the things that happened during the early days of the pandemic is NIOSH, which was a division of the CDC, was really silenced a lot by the administration. And they have really state-of-the-art information on airborne transmission and how does, for example, certain kinds of N95 respirators versus surgical masks work and how effective they are.
And that was known already.
It was all known.
Yeah.
And we also knew from the standpoint of airborne transmitter-related virus, plexiglass shields did nothing,
That seemed obvious to everyone, actually.
Yeah. And I tell people a very brief story because this is an example of an aerosol. I worked on a very interesting outbreak of measles when I was again at the State Health Department.
Yeah.
We had the International Special Olympics that came to Minneapolis, and the opening night session was held in the old Hubert Humphrey Metrodome. Held 68,000 people plus everybody in the infield, outfield area. That night, one young boy from Argentina, the Team A, was breaking with measles. We had not had measles in the Twin Cities area in the previous 3 years. Yeah. And it turned out that a number of people associated with the games did, in fact, develop measles. But we had several cases in residents of Minneapolis, St. Paul, whose only contact with the entire event was that opening night session. And it turned out that we had cases that sat only in the farthest away seats, way up in the upper right field bleachers where the air outflow was from the air that came off home plate, 420 feet. Nobody between home plate and this little section got infected. And in this section, people did.
Wow.
And to the best of our knowledge, based following up with people who had been sitting in that section, the only people that got infected were the people that had not either been vaccinated before, who had not had measles before. Think of that, how dynamic that transmission was. And that's airborne transmission. And so that's why we have a number of real life experiences to say, you can't dismiss airborne transmission.
Well, and I think one of the things that we all became experts on, that just your slide reminded me of, that I'd forgotten, is just how much more effective N95s are than, let's say, a surgical mask.
And and then we had to explain to people why. One is the fit. How many people have ever had their swim goggles leak because it leaked in the glass? It leaks in the fit. Well, if you get something fitted so tightly and it's airtight, you suffocate. So what makes N95 respirators so special is it's what's called melt-blown material. It's a type of material that has an electrostatic charge in it. And the pore size is big enough to let air move through. And technically a virus could come right through except for the charge. And so it stops it. And so nobody's going to suggest N95s today are the most comfortable, I can't wait to wear one kind of thing. But at the same time, because of that melt-blown material, you can breathe for hours and not have to change the seal around your face. And that's what protects you.
Well, and I think that, I don't know where everybody who's listening to this is in their masking now. Some people mask never. Some of us, like me, are sensitive to the fact that I don't really want a cold virus either, never mind flu or COVID or RSV. And there are a few places where, it's almost impossible, but when we're traveling is often a place and time where we worry about being in. But sometimes people worry in the wrong place. Like I think that the airport where everybody's moving around and there's a huge airspace, I think we saw it with the carbon dioxide monitors. Like it's where the air isn't moving and where you're in the little corridor down to the plane, or when you're on the plane before they turn on the HEPA filters.
You're absolutely right.
So I think it is still possible to be quite rational about how to use those masks to reduce our general chances of airborne viral illness. But yeah, great reminder of some of that science that was like front page news for a while, and maybe not quite front page news anymore, even though perhaps it should be. So we move through on our pandemic timeline, obviously, and we get to vaccines. I think people have forgotten what a miracle it was, because I remember, one thing I remember specifically was the New York Times had built this predictor of the most likely time for a virus if everything went well. And some of it was based, of course, on all the previous viral development, and including the idea that some things like HIV, there was really never a great vaccine developed. But I would move the sliders around, and you know, some of us, of course, we were like, well, everything went really, really well. I think it got down to 2.5 years or something, but it went up to 15 years. And so the most likely seemed to be 4 or 5 years. And that was like the accepted wisdom. And yet 10 months in, we basically had phase 3 trials for 4 different vaccines. From your perspective, you have this unique perspective on this. How do you think of it now?
Well, you know, first of all, it is remembering what has happened in the past in such a way that it helps reflect on why you're doing what you're doing right now. The year I was born in this country, there were 55,000 cases of polio, of which over 21,000 were paralytic. That's in my lifetime.
21,000 people paralyzed. Yes.
And so, you know, you have to remember that we likely will never return back to those days because enough people are vaccinated. It will surely reduce the risk. But it's still the potential for huge, huge outbreaks. And, you know, one of the things I've mentioned today also was we're watching very carefully what's happened in Canada with measles. You know, last year they had over 5,500 cases. Their rates of vaccination prior to last year were very similar to what ours are now in terms of actual hotspots of low vaccination, et cetera. And Canada has a population of 40 million. We have 340 million. If you just do the population adjustment, given what happened in Canada could happen here, that's over 40 to 45,000 cases of measles that could occur here. People say, well, that's never going to happen. Well, if you'd said to Canada 3 years ago, you're suddenly going to have 5,500 cases of measles, I said, it never can happen. And so I think that part of what we have to do is keep reminding people that, you know, the potential for an infectious agent, the reason you and I went into this business when people were telling us not to, is how dynamic it can be and how it can change so quickly. And I think that's why vaccines are so very, very important. That's the one stopgap measure we have that still is the one powerful tool. You know, our treatments are limited for many of these infectious diseases, but what we do know is the vaccines can be very effective.
I mean, I think you're right. It's a short-term memory issue in many ways, and I mean, polio, your example. I was recently had reason to read about the history of smallpox, and I haven't done that since I was a medical student. And that is just it's terrifying reading. I mean, just
well, you know, and it's likely to potentially get much worse. And I say that because, you know, I had the good fortune to work with Dr. D.A. Henderson very closely at HHS right after 9/11, and D.A. was a mentor to me for many years anyway. And as many of you know, he led the WHO effort to eradicate smallpox with the, you know, the very important support from people like Bill Foege, who really helped lay that out. And one of the things D.A. and I used to talk about was the fact that what would happen now if somebody could make smallpox virus. And as you may or may not remember, the decision was to sequence the virus back in the 1990s because the debate was, should we destroy it or not, with 2 stocks left in the former Soviet Union and the United States. And the decision was, well, until we figure out, let's sequence it. So the sequence for the virus that causes smallpox, the orthopox, is all public information. There was a group in Canada several years after that that actually took and made horsepox de novo from the sequences and the published material, and they actually created a pathogenic horsepox virus. It can be done. And so I worry that today with modern technology, 20 years later, it's even easier to do that. What would ever happen if somebody brought back smallpox? And, you know, you can say, well, that'll never happen. Well, you know,
it's terrifying.
It's real. And you know, right now, you know, virtually since 1978, almost no one's been vaccinated for a pox virus like that, except more recently with mpox. But you know, think of what the world would be if we suddenly announced we had a smallpox outbreak sweeping through the United States.
That's a terrifying prospect. The vaccines, however, are our way out.
Yeah.
Right? Whether someone has created a virus or not, and I loved, the audience also loved your response to the lab leak versus natural origin hypotheses. It's like, please, you repeat it for our audience.
Well, I just say move on.
Yeah.
We will never know.
Yeah.
I mean, there's data that clearly supports a lab leak.
Yeah.
There's data that supports spillover.
Yep.
The point being is we're fixated on this and we're not planning for the future.
Yeah.
And to me, we have to plan for either one.
Yeah.
You know, I'm willing to accept that there could be a lab leak in the future. I'm willing to accept the fact that there's going to be a spillover.
Let's plan for
what
that.
we're doing right now is not preparing for either one, because we're hung up on trying to say who's right and wrong about the original source of the virus.
Yeah. But I think the demonstration, I'm a genomics person, and I think the demonstration that genomic technology, by understanding viruses and understanding the delivery of RNA in particular, but even the DNA that was delivered as part of the adenoviral.
Exactly,
exactly. So we have essentially digital vaccines now that we can dial up and be prepared for and potentially scale globally.
Yep.
We haven't done that. In fact, virtually nothing has happened since the end of the pandemic in terms of preparedness for the future.
In fact, I would go so far as to say it's gone backwards.
Is that right?
And, you know, before the Biden administration left office, they basically identified $500 million to go to NIH/BARDA for the development of mRNA technology vaccines for influenza and coronaviruses and to better improve the coronavirus ones. This was really important work because right now, if we had an influenza pandemic, for example, the primary source of vaccine would still be the inbreeded chicken egg that we have.
Yeah.
And that, unfortunately, is at risk with H5N1 right now, even in the barns that grow these inbreeded chicken eggs.
Right.
But then on top of that, if you look at the total capacity globally, and we just published on this, it's about 20% of the world we could make enough vaccine for in the first year to protect them.
Right.
Whereas if we had an mRNA technology vaccine, we believe in the first year we can make enough effective vaccine to vaccinate 100% of the people in the world. The difference between those two scenarios is millions and millions and millions of deaths.
Yeah.
And yet this administration took away all those resources that were there for that kind of purpose, and we're not doing that work.
I mean, I think we're all global citizens. I mean, we lived it together. That was one of the few times that we really truly understood that we were global citizens. If you think about, I'm a sci-fi fan, think about all this sci-fi, the aliens come down to the planet, right?
Yeah.
I mean, humanity has to come together, but where is the forum that humanity comes together? Now, if one country that happens to be richer than the others is willing to lead, that's good. But where is this world of nations, like who the aliens talk to in the movies, that can decide that as a global community, this investment has to happen, and we're all going to pro rata pay into an account to make it work? Yeah,
and we keep hearing about this mantra, America first. Mm-hmm. Right now, we are so far behind in mRNA technology for influenza vaccines. Yeah. We would be in line to get vaccine from countries that have already advanced this work, okay? Yeah. Now imagine us getting in line right now. Do you think we'd have a lot of sympathy from these other countries who are saying, you've made this case for yourself, get in line? Yeah. And I think that's a challenge to think that it's not America first right now. We'd be potentially way down the line in getting vaccine.
Yeah. And so this is a tale of two chapters. One where we have this biotechnology revolution that has delivered something that 100 years ago we didn't have. And with the Spanish flu pandemic, obviously, they didn't know what it was. They couldn't sequence it. They couldn't produce a vaccine. We have that potential now, but we are not only not poised, we're making no preparations as a country and even as, I think, a global community. I mean, you shared some of the rather frightening possibilities. I think we all knew them. We just choose not to think about them. You talked about bats in particular, because I think we forget that although this version of coronavirus had a fatality rate, first of all, it was mostly hitting older people with comorbidities.
Right.
But we know there are flu strains that have a much higher case fatality rate, just without scaring us too much.
Yeah. Well, no, I think, again, I just come back to the issue of SARS and MERS. Yeah. What helped us contain those viruses was the mechanism by which they basically infected a human. Yeah. And it was not nearly as perfected as we saw with COVID,
Yeah.
okay?
Yeah.
The problem is we now have identified viruses that have the package on board to kill, like MERS and SARS, 15 to 30% of the people who get it.
Yeah.
And at the same time, they now have the ability to be transmitted at this very high rate.
Right.
And that's a scary proposition. I tell people, if you want to know what that was like, think of living during SARS-CoV-2, where 1.5% of the people died, and how bad that was. Now imagine if you put a 15 or 20% case fatality rate on that. What would this world be like?
And this isn't theoretical.
This isn't theoretical at all.
No.
This isn't even a stretch in terms of, well, that could never happen.
Yeah.
I mean, this is, and as we do more and more work in the world of the jungles and so forth, we're going to see more and more of these viruses coming out.
Yeah.
And the fact is, we kept focusing on China relative to these potentially very serious coronaviruses. Now we've found them in the Amazon.
Yeah.
So it's a much larger picture that surely poses a lot of risk.
So what would you do if I handed you the checkbook for the U.S. government? Like what can we do? I mean, we can't make a vaccine for everything.
Vaccine for those that pose the greatest risk.
Yeah.
But
do we make them in advance and store them in a freezer? Do we have them in a data vault ready to?
If you devise the technology appropriately, where you can very quickly plug and play, we can make some of these vaccines like mRNA technology very, very quickly.
Yeah.
So we have to have though as the template to do that. We have to have the data pre-pandemic that says, if I put this into you as a vaccination, it'll work.
Yeah.
Okay. And so I think we can do a lot of that preparatory work that would allow us to quickly move.
Yeah.
I wouldn't say stockpile a bunch of vaccine right now, because you're right, we want to make sure we have the vaccine that really works.
Yeah.
I think that's the first step.
Yeah.
The second step is that we do need better vaccines other than mRNA technology too. That, as many of in this business would say, is the first dose out will be an mRNA vaccine. It'll prime the system, protect you some, and then we need a even different vaccine later on. And our center actually leads globally efforts around developing roadmaps for both coronavirus vaccines and influenza. If you go to our site, you can find out where every vaccine that's under research is, what their progress is right now. And we do need, and I do believe we can get better vaccines. And it's not just a pipe dream. But right now, let's just cover that initial hit, have the mRNA technology available.
Yeah, that makes sense. And I mean, I think people will often ask about, and you touched on this a little in your talk as well, the difference, the truly seasonal, I guess, whatever the true season, you made the joke about that with coronavirus, it could be any season.
Yeah, it's seasonal because it occurs in every season.
Every season, right. But I think people are used to thinking, well, I got the flu vaccine last year and I still got flu, like that's a terrible vaccine. I mean, that was the bar. We were hoping that the coronavirus vaccine could leap over it. It turned out cleared it by a mile.
And I tell people you're absolutely right, but on the other hand, had you not been vaccinated, you might have been hospitalized and seriously ill. And we have data that clearly shows that can be the case. And so this is an example of where I said earlier about mandating vaccines or not. I find that because of the lack of total protection, the ability to interfere in transmission isn't really clear, that this is maybe not a vaccine you want to say is for the whole community, but it should be for you, meaning that I strongly encourage flu and coronavirus vaccines. I get mine. But just knowing that it may be a situation where you could still get infected, but with the data are clear and compelling, it substantially reduces serious illness, hospitalizations, and deaths. I'll take that anytime.
Yeah, and we hope, I think, that most people would choose to do that. But it's complicated, of course. I think there are most of the health conditions that we think about and talk about aren't ones where whether you decide to treat yourself or not could decide whether your neighbor survives or your family member survives. So it is definitely complicated, and we've certainly all lived through years of trying to think through that. We have your new book is here. This is the newest one, I think.
Yes, it is.
Yes, the big one.
The big one.
It's and it's about just what we're talking about, how we might prepare for the potential of future deadly pandemics.
Yes, thank you.
I mean, we're excited to learn about it. We're a little scared, to put it mildly, but we should be. But I think it's very different from the scared we should have been in 2019 when this technology wasn't proven and we didn't know we could do it. You know, when we saw within 10, 11 months us go from sequencing the virus to delivering a phase 3 trial with a 95% outcome measure. Just remarkable. So, well, I think another remarkable thing is your incredible career.
Thank you.
And we're really grateful to you for coming to Stanford today to give our Merigan Lecture at the...
You know, I'm very, very honored, and I think one of the things that most people don't necessarily know about the Merigan Lecture and who Tom Merigan is, Tom was very instrumental in my early days in terms of following him as a real leader. He went into virus treatment and antivirals when nobody was going there. You know, and he really was very helpful in kind of establishing what we could do and how we can do it to actually treat virus infections. And so, you know, he's always been a pioneer hero of mine, and it was just an incredible honor to be here today.
Yeah, to have him right there in the front row.
So,
thanks for coming to Stanford.
Well, thank you, and thank you for having me. I appreciate being on the podcast here with you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.